people don't care about their doctor's social justice commitment. And they don't care about what race the doctor is. They just want a good, competent doctor who knows what the hell they're doing. Well, hello out there in podcast land. Welcome to a new edition of the Liberal Patriot Podcast. I'm your host, Ruy Teixeira. I come at you every couple of weeks with the very finest and heterodox conversation and analysis with the most interesting and stimulating guests. And today I'm delighted to have my AEI colleague, Sally Satel, with us. Sally is a resident scholar at AEI, and she's the medical director of a local methadone clinic right here in Washington, D.C. She was an assistant professor of psychiatry at Yale from 1988 to 1993, and she remains a lecturer at their medical school. She is widely published in the academic and non-academic literature and is the author or co-author of many, many books. For our purposes, I'll mention PCMD, How Political Correctness is Corrupting Medicine, and a book you are currently writing, tentatively titled The Indoctrinologist Will See You Now, Medicine in the Age of Social Justice. And just today, some themes from the latter, I think, were in a post on the Great Heterodox STEM Substack, which I guess was taken from a talk you gave to a conference, Medicine in the Age of Social Justice. So let's start with that part of your work. PCMD came out in 2001. And here we are a quarter century later. What's happened in between? How bad was it then? And how much worse has it gotten?
Well, in fact, the conclusion of PCMD was called "The Indoctrinologist isn't in ... yet."
Yeah.
And 25 years later, he or she or they are in. So the original book was really something I was seeing on the horizon. And I divided it into kind of disciplines. Like there was a chapter on nursing, and that had to do with, not all nurses, of course, but some fairly vocal minority who saw their profession as being put upon by the patriarchy of medicine. And on that basis, they were embracing alternative treatments, unconventional treatments that, perhaps if they were put to rigorous tests, might have been shown to have some effect, but weren't. And they were also using ones that clearly had no effect. And this was almost in protest. Now, to be fair, they weren't doing this instead of surgery. If you needed your appendix out, it came out. But they were involved in other ways, probably the most harmless of the whole thing, other than the fact that, you want nursing to be based on science and evidence-based practices. And then there was a chapter on public health, which is one that a lot of the same themes I described then are very much present now. And they have to do with basically seeing oppression now after George Floyd, more systemic racism. At the time, it was more generic oppression as a factor in health. Yeah. Along with housing and wealth and environmental exposures.
Sure. I mean, I think that was the original argument, wasn't it? There was a sort of school of social determinants of health, which were like SES and healthcare and education. I mean, it was like, these are clearly correlates of some kind. But then they layered onto it this whole idea, there's also this matrix of oppression that connects to people's health, and we need to deal with that. And that becomes transmuted, I guess, into docs should be fighting oppression. That's like part of health too. So,
yeah, well, there are several reasons why I don't feel that's constructive or healthy for our profession. Which I should say there are forces. I can read you some quotes from the American Medical Association, the Association of American Medical Colleges, and onward that actually seem to want to change the mission of medicine from healthcare to social justice, and the identity of doctors from healers to to activists, that's a little hyperbolic, but as I say, I'll read some quotations.
Yeah,
later.
hit us with a few of those, because I think people aren't maybe aware of how far this is.
Okay. And the fact that people might not be aware is exactly the reason, we're going to get to this later, why I don't talk that much about trans issues or even the post-COVID lockdown issues, because they do have, and rightly have, so much, such a high profile, but this doesn't. So the AMA, in its 2021 organizational strategic plan to embed racial justice and advance health equity. This says that doctors ought to, quote, confront inequities and dismantle white supremacy, racism, and other forms of exclusion and structural oppression. And they mean that within the field and also within the field of medicine and also in society. And every professional organization, I mean, anyone who's a doctor after the George Floyd murder was just besieged with every organization, the American Academy of Pediatrics, the American Psychiatric Association, the AMA, the American College of Cardiology, on and on and on. These kinds of commitments, how performative they were. You might want to say, well, they were just performative, but as we'll go on, they weren't just performative.
Yeah. Well, I mean, on the face of it, it seems batshit crazy. So how did this happen? How did seemingly intelligent people decide that somehow this was an intrinsic part of medicine, was turning people into anti-racist freedom fighters? I mean, it seems utterly bizarre that that this would actually be promulgated in the entire field of medicine. Wow. I mean, wild. So, I mean, who was behind it? How did it happen? What are the mechanics of this?
Well, that's what I hope my book will answer.
Okay.
I have to say that there's a long history of activism in the profession, physician activists. In fact, in the very old days, like going back to the 1800s, that's all we had. Sort of was activism. And by we, I mean, I really am talking now public health, because doctors could not do we'd give you opium in the 1800s, we bleed you a bit, and maybe some laxatives. As you know, medicine was
pray for
useless.
the best. Yeah.
And, and the hospitals are where people went to die. But and that's what, and public health, and this is why I think it attracts so many folks who have political instincts, or I should say policy instincts that are sometimes politicized, is because, especially in the old days, that's what health was. It was the sanitation era. You had to have, clean water. There had to be sewage. Malaria, swamps had to be drained, so malarial, mosquitoes didn't breed, and so on. So, and that was all. Those activities all took place on a large stage of involving health authorities and politicians. And so there's a strain of that in public health, and with some good reason. But that, I think, made a lot of folks in the field of public health very kind of comfortable with this. In the 70s, the notion of social determinants of health became codified. I mean, it's been true ever since, for humanity. And then it was, as you alluded, very responsible. I mean, it's a fine topic for research to try to, I mean, a lot of it's correlational, but to the extent that you can conduct research that illuminates a causal relationship, that's wonderful. So it's a good area of study. It's even a good area of education of politicians. They need to know that housing projects breed roaches, and roaches actually exacerbate asthma in young kids. I mean, that's something they need to know about. Then they go off and do the housing policy. So that's point one, is once these relationships have been described, who's responsible for fixing them? And it seems increasingly a certain strain of physician thinks they are. And that's a real problem. So that's number one. And number two is, like, when you start talking about, at least I mentioned housing. I mean, that is something specific. But when you're talking about these vague upstream factors like, racism and the economy and social justice kinds of things.
And like capitalism, man. Capitalism is what causes oppression, man.
First, they're not actionable. I mean, what do you do? What lever do you pull to affect that? And if you did, God knows what would happen downstream. And secondly, what the hell do we know about this as physicians? Nothing. So, so that's one of the real red flags that is starting to wave, is that the sense that being an activist is part of it, becoming part of a physician. Let me add, though, before you say something else, I think it is perfectly legitimate. I have 3 rules that I've constructed with a Dr. Thomas Huddle, 3 rules for activism. The first is that whatever it is a doctor is fighting for, and which they can do on their own time with their white coat off, anything they want. But as physicians, if they are interested in becoming involved in reform, the object of their reform should be, according to our rules, policies that have direct impact on patients, just direct impact. So I think it is perfectly legitimate for physicians to be up in arms, and I join them in cuts to Medicaid, these kinds of policies that will have direct effect on patient care. So the first of the 3 is that their object of their activism or advocacy, I suppose, should have direct effect on patient care, proximate to patient care. Second, it should be something that doctors have deep and unique expertise in, because otherwise we're basically abusing our authority as physicians to get involved with something that we don't really know about. And few doctors, and why would they, know how to, as I said, reform housing or environmental toxins or other things. And third, they really have to take into consideration the effect of their activism on their colleagues and patients. An example, a really shocking example that I use for this took place in June of 2024, when physicians were outside on the medical campus of the University of San Francisco Hospital. And many of them were wearing keffiyehs, and many of them were screaming "Intifada, Intifada," and it could be heard in patient rooms. And this is just an outrage, and the hospital took a very long time to attend to it. So, how are you going to work? Putting aside the fact of how frightening this could be for patients to hear, that you have to work, with your Jewish colleagues to take care of patients. It's a lot of collaboration. Anyone who's watched The Pit, you see that. That's in its most dramatic form. But so we really have to be very careful about physicians moving into this realm.
Yeah, once things get politicized, everything goes sideways, basically. And as you point out, things that have a political valence one way tend to alienate people who go the other way. So there was a nice chart in your Heterodox STEM article about the political valence of statements made by medical associations of various flavors. It's like 95% of them were liberal, right? And like 2% were conservative. So it's like basically you're transmitting to the world at large, to politicians of various stripes, medicine is like this liberal redound, where we're totally down with all the political positions of the liberal part of the political establishment, which is fine. They can have their own opinions, but what is the point of being so politically direct and out there? You're just making yourself a target, and you're getting, as you say, over your skis. You're getting out of your lane. What people want to know from doctors and from medical associations, what works, what is effective?
Of course. Yeah. Going back to your original question, I suppose, is how the hell did we get here?
Yeah, how did we get here?
Yeah, I have some thoughts.
Okay.
And it's never one thing, as you know. But one is that, medicine still is an academic institution, or medical schools, and this is, as you can imagine, ground zero of all these trends. But so it just was swept along with everything else, in in the recent, well, you could maybe start with postmodernism, but whenever, it was swept along with all the trends in universities. And that's who's populating these things, increasingly young people from universities where they've been steeped in much of the social justice catechism, as some might call it. Then I trace some of it to the fact, this goes back quite a ways, but how changes in funding or changes in the organization of medicine. It's not that easy anymore to be a solo practitioner. It's not, medicine is not that welcoming to entrepreneurial physicians. People work in HMOs, people have to, and insurance has gotten much stricter in many ways. So doctors have less latitude. So people who want to, be creative in certain ways, are risk takers, which entrepreneurs are if you want to start a practice on your own. They are probably migrating away from the profession. And we have seen, it's well documented that the profession is very right-leaning. Very left-leaning.
Yeah, left.
And there's an age gradient. So the younger the cohort, the more that's pronounced. And so I think that speaks to who is coming to medical school. Then, you can imagine, you have young people in college who are thinking of medicine, and to the extent that they see these trends, they think, well, this is necessarily a place for me. I have two more theories. One is also, I think, a product of prioritizing lifestyle. Now, that has nothing to do with any of this identity politics, but that's been a trend in medicine for a while for trainees. And, it can be brutal. I didn't go to Johns Hopkins, but if you went to Johns Hopkins for internal medicine, you were on call every other night. That's, maybe if you're 25, you can handle it physiologically, but that is brutal. And so there have been calls really for decades to be somewhat less demanding. And I think that makes sense. So there's that again. And I say that to the extent that it brought a little softness with it, maybe. And then finally, I think we hear so much in my field about burnout of doctors, and again, having nothing to do with these politicized trends. But 5 minutes, I can't even fathom this. 10 minutes with a patient, thank goodness I don't work in an environment like that. Tons of paperwork, not being able to get a prior authorization for a therapy your patient needs. That's a prescription for a moral injury. And so physicians are demoralized often and burnt out. And I think in an environment like that, you tend to, if you're one of those folks, you tend to take a more passive attitude. And fine, if you want to march, just fine, Right. And I think I think it's a combination of all these, maybe more. Sure. And if anyone has any ideas, please contact me.
Yeah, right. So I think part of it is clearly a cohort phenomenon. The people who decide to become doctors, who went through the educational pipeline today and in the recent past, are pretty different than the people who did it 50 years ago. Actually, there's good evidence that back in the day, doctors were actually pretty right-leaning. So there has been this not only a change, but almost a 180-degree transformation in the politics of docs. So this clearly has to have something to do with cohorts. So in a cohort that, as you're saying, is both more steeped in social justice, more oriented toward, and also in some ways more conformist and keeping their head down. So the people who are the activists in the cohort basically can, in a sense, hegemonize the entire profession by virtue of the fact that a lot of people are keeping their head down. And I think this is actually part of it too. See what you think of this idea. I think there's been the institutional capture of the medical authorities, the trade associations, similar things. That's pretty huge. And that's basically activist driven. It's not that hard if you get a few people in the right positions to basically become the spokespeople for the entire profession, which then creates a feedback loop between, what the docs in that particular area do and say and what's reinforced at the top of their professional sector. How else can you explain how quickly a lot of these things happen in, the AMA, the pediatric psychological? I mean, you name it. You
Right.
name the discipline. They all started speaking from the same anti-racist hymn book. You don't have to get too much into gender affirming care, but I mean, just with lightning speed, all of the associations essentially endorsed pediatric medicalization of minors as the correct approach to gender dysphoria
Right.
in children. So, I mean, this is that's wild that it happened so quickly, and it's wild that it happened so uniformly, and it can't be explained other than, not only did they have a receptive audience, but in a sense, they captured those institutions and took advantage of the fact that once you do that, you have a massive megaphone.
Yeah. And one thing I'm looking into is the fact that all these trends were there, and in fact, PCMD was about that, but they were much fainter. So it didn't come out of the blue, but it was really accelerated tremendously after George Floyd. And we could throw in another thing, since it's about heterodox topics, a little hat.
The safe space, Sally, safe space for heterodox ideas. So hit me.
I say a little hat tip, maybe to Helen Andrews. I'm not sure. I think she perhaps went a little overboard, but medicine is now has many more women in it than men. And when you said conformist, that if you want to subscribe to her philosophy, which has some merits, has some points. Conformism is sort of another trait of women. Justice sensitivity is on average a trait of women, and so that could make the student bodies more somewhat more sensitive to these activist preoccupations.
Sure. I mean, it could be an amplifying factor. I find that pretty credible. I mean, one can reject Andrew's monocausal explanation of all these social changes, but on the other hand, it'd be kind of silly just to toss it out as something that has no influence at all, when it's been a big sort of important demographic transformation. And what we know about the politics of young women, especially young educated women, and how they differ from everybody else. So obviously something's going on there. So yeah, it's all these things have kind of come together to create this sort of social justice, medical industrial complex. So what do you think is happening today? I mean, obviously the Floyd thing was, and the year or two after that was like the peak of some of this stuff. But now a lot of these things are entrenched. Do you feel that, are things getting better? Is the volume on this stuff dying down, or just people? I mean, one of my theories is maybe they're just going to ground, because once you've captured institutions and you've got the true believers in charge of a lot of them, and people have pretty hardened ideologies, they may be saying and doing things not quite as aggressively as they once did, but they retain basically the same orientation. Do you see glimmers of change here, and to what extent? Is that hopeful?
I don't, and I should say I've been talking to colleagues who are, in the white hot center of medical centers. I mean, I work in a small clinic, so, but all I have to do is look at the journals, and they still have basically articles that are driven by very little data, but long on grievance. And after the affirmative action case, the Supreme Court was decided, there were so many articles about medical school in medical journals, even one in Stat that was about the deans who were just bereft and trying to figure out how they might reshape racial preferences, but in a way that is more acceptable. So no, I actually think that when people say, peak woke, whatever, I'm perfectly willing to believe that might be manifest in some sectors in society, but I don't think that's true in medicine. And I think people are, like in many institutions, a lot of eggshell walking, a lot of senior people who've amassed so much knowledge and experience, basically saying, I don't really have to teach. they're stepping back. A lot of teaching in medical schools, especially in the last 2 years. The first 2 years are done more according to a formal lecture kind of format. But the last 2 years are all with patients, and they're done in very small groups, like the senior doctor and then maybe 3 or 4 medical students, and they talk to the patient. And it's the best part, really, and it's where you learn so much more subtlety and how to interact and bedside. A lot of folks I've spoken to said, I don't need this, because they can just step on a microaggressive landmine too quickly, and many of them have. I've heard those horror stories of, the student went to the dean and said I was insensitive. Meanwhile, this is
tell that story, Sally, because that's a good one. I mean, and that happened to you personally, where it was like this completely bizarre outpouring that kind of you got.
My story, I feel I have to preface it by saying I am fully aware that people have been had horrible cancellation experiences. I consider mine more like a biopsy of the body politic of medicine.
Okay.
It just revealed something really ugly and unfortunate, but thankfully I didn't suffer that much. And a shout out to the chairman of psychiatry at Yale, who did not, even though he was pressured, fire me. I still have an appointment there. But to just be brief, I had been away in a rural part of Ohio for a year, 2018 to 2019, helping out. I'm an addiction psychiatrist, so helping out there and interviewing 1 million people. And so when I got back, I gave this talk. It was by Zoom because it was still COVID time. And it was called My Year Abroad, Ironton, Ohio, and the Opioid Epidemic. So Ironton, Ohio is a small town. And so I spoke about, I showed some pictures of the place. And, it actually could be a beautiful place, but there was so many rusted factories.
It's a deindustrialized Ohio town. Yeah, where the community's been blasted apart. We should,
exactly,
that shouldn't be controversial.
Like the backdrop for the deaths of despair drama. I didn't have pictures of individuals looking distressed or, just the landscape. So I talked about deaths of despair. I talked about my view of addiction, which is heavier on personal agency than many others. I talked about I talked about what I call the web of dereliction that led to the opioid crisis, and that if you wanted to just blame Purdue, you could. And I think they do deserve blame. So don't get me wrong, they deserve it. But from an analytic standpoint, the standpoint of analysis, if you just look at the supply side and just look at one element of the supply side, you're going to miss the whole dynamic, the very complex dynamic of what went on, all the variables on the supply side, the others on the demand side. And those are the highlights of things that could, and I also, in passing, mentioned, some of the folks that I had met there, and I still keep up with them. And one was a gentleman who he was a retired chemist. He worked in one of the chemical plants, and he started his own little artisanal coffee shop. And I said offhandedly, wow, you wouldn't expect to find that in a town of 10,000. Anyway, so that's basically the layout. And it was just not, let's just say it wasn't received well. I was, some of the students, and this is classic, right? You don't know how many. You just get a letter that's
just
unsigned.
Takes a few, yeah.
Concerned residents, at Yale. And it wasn't clear how many. And they thought that I was, they just accused me of being classist. And then they read other work of mine, and then so they could throw racism in there, because I've written a fair amount about health disparities. And they were deeply offended that I was skeptical about finding an artisanal coffee. I know this all sounds ridiculous.
But that's,
how dare I talk? How dare I talk about agency and addiction? Because everyone knows that people are, completely at the mercy of their environment. well, they are in part at the mercy. They're sure they are, but so I remember one of the one of the residents said that to me. How could you say that? I said, well, I don't, really muster up for not, feeling really frustrated with him. I said, well, that's your job. I mean, if you're a clinician, your job is to start to usher people into recovery. And that means nothing less than harnessing the remnants of will that a person has. And then you work with them. There are a million levels on which to work with the person. But the ultimate one is how to, rebuilding a life. But when it comes to addiction, from day one, if you don't have motivation, you're not going to, it's over. Now, at a later time, you might have motivation. And when you get to learn each individual, you see why they might not have motivation, because their lives are so difficult and the drugs are such a powerful oblivions that they want to stay there. I get that. Anyway, I'll speed it up. But a month later, very important, this talk took place on January 8th, 2021. So a month later. Oh my
goodness, that was only 2 days after January 6th. What were you thinking, Sally? Isn't that what they said?
So he got a letter from one or 40 of these people saying, how could you invite her and not tell us? She has a history of writing about race, and she's classist, she's racist. And we were re-traumatized after January 6th. It was just,
gotta toughen up
I should
these
lose
people.
my appointment and all that. So thank God he didn't do it. But, you know what? I still am having trouble, teaching my, I had a little seminar that I did. It was short. I mean, it was a one-day thing, but, I still can't get back. I was told to last year was too soon. So I don't know. But I think this year will be different. I think I'll get to do that. But there are people, that take Norman Wang. I mean, he's a serious case. This doctor is an electrophysiologist, a cardiologist at University of Pittsburgh, and he wrote a very considered article, is peer-reviewed for the Journal of the American Heart Association, on why affirmative action is not helpful for his profession of cardiology. And basically, he was stripped of his ability to run a fellowship. He was not allowed at first to have contact with students. He was just savage on Twitter. Mm-hmm. And and his paper was retracted.
Yeah, it was retracted, yeah.
There were some nitpicks, but nothing a letter to the editor could, and then his response couldn't have satisfied. I mean, it was, of course, it just peaked COVID anxiety and peak woke, but, and he's still teaching, and he's still treating people. Thank goodness, because he has a wonderful rating. He must be a wonderful doctor. And electrophysiology is like the quantum physics of medicine. It's very, very difficult. But he's sued a few times and not successful, but he's renewed his lawsuit. And that's a tragic case. So, and then other doctors, as I mentioned, just the chilled, the collegiality has taken a hit. It's really hard. People get berated for, a colleague of mine said that she was in a seminar discussing higher rates of suicide in young Black men, which is true. That used to be quite low, but now it's increasing. And the only explanations that were kind of acceptable to be considered were police brutality, or again, more generically, systemic racism. Nothing about bullying, nothing about their fear. So many of these kids are scared of gangs. They don't want to be recruited into them. Right. That's so stressful. And there's bullying at school, and then there's often not having a good older man in your life, and maybe your mom's working 3 jobs, or maybe she's a heroin addict. But in any case, it's hard lives for these kids, and you couldn't entertain other explanations.
Yeah, no, it's become a bit of the art of the ignoring the stupefyingly obvious when you do medicine and medical analysis, which is like just crazy. I mean, it's just like so antithetical to what research should be about and what the practice of medicine should be about. And you bring this out in your article and your other work. The fact of the matter is people don't care about their doctor's social justice commitment. They don't, we'll get into this, and they don't care about what race the doctor is. They just want a good, competent doctor who knows what the hell they're doing. And, you can ask people in a lot of different ways, and they always say the same thing. So you're giving people something they don't want, which is a social justice oriented doctor or the social justice oriented researcher, when actually what a normal person just wants, be they black, white, or polka dots, is to have a competent physician who'll actually cure their problems. So, but let's get at the thing about, the race of the doctor, because I think that's such a incredibly interesting example. And this was the infamous Black baby study, which was alleged to show that babies who were taken care of by white doctors had twice a high a chance of dying.
Black babies.
So black babies, right. Black babies taken care of by white doctors, and if they cared by black doctors, have this. So this was like an incredibly flawed study, but it was adopted wholesale by, the usual suspects. And, Ketanji Brown Jackson, now on the Supreme Court, cited it in some of her discussion about affirmative action in medical schools and why it was still a great idea. And yet the whole thing was built on sand. So tell us a little bit about that case, because I think people, I get dollars to donuts. Most people who've heard of this case or this study still believe the study stands, right? Because that's what got the publicity. The demolition of it did not. So tell us about that.
Right. So this study came out in 2020, I believe, but it was in the Proceedings of the National Academy of Sciences. And the title was, I apologize, I don't have the title, but I can tell you how CNN discussed it.
Okay.
They said, their big headline, and it got a lot of attention in the media. CNN was certainly not the only outlet. Black newborns more likely to die when looked after by white doctors. And part of it, that's the headline. And part of the text was that this study, quote, laid bare how shocking racial disparities in human health can affect even the first hours of a person's life. And so it turned out that's, very dramatic. Ketanji Brown Jackson cited it in her decision against, in the minority ruling of, Harvard versus for Students for Fair Admission.
Yeah, the big affirmative action case. Yeah.
And the idea there was if we need more Black doctors, because that will help us solve the disparity problem. And disparity, of course, means differentials between groups, in this case, having to do with health status or access to health. And those are real disparities. Sure. The question becomes, are the proposed solutions any way to fix them? Spoiler alert, no. So anyway, back to the babies. So yeah, this was a study that looked at several years, over a decade, I think, of data. It was retrospective data on Florida newborns. And it turned out that in their study, which oddly did cover a lot of variables. I mean, it was striking to me but they left out one of the most important predictors of neonatal health, which was birth weight. Low birth weight is under 1,500 grams, and they left that out. And to their credit, they gave all their data to another group that reanalyzed it and found that when you took low birth weight into account, which was a data point that was available, that this effect, the alleged effect of it's called racial concordance, doctor or patient having the same race, didn't affect anything at all. The reason why the Black babies were more likely to die was because of the low birth weight. And the reason that their doctor was more likely to be white was because when you're a newborn and you are seriously underweight and unhealthy, you go to a neonatal ICU, and 95% of all neonatologists are white. Mm-hmm. So, you really don't have to be Sherlock Holmes to figure this one out. And when that happened, the effect almost completely disappeared. I can read just a sentence from the correction, which was published. Well, it's not a correction, it's a reanalysis from 2024, which they published in the Proceedings of National Academy of Sciences. And it said, we find that the magnitude of the concordance effect is substantially reduced after controlling for diagnoses indicating very low birth weight. In fact, the estimated effect is near zero. But a lot of times the disparity, so to speak, doesn't melt away, because you left out a variable. It's real, but you cannot reflexively say it's due to systemic racism, which just happens too much. I'm not saying there aren't physicians and researchers who are.
Where's people's bullshit detector, right? I mean, how does this possibly work that these white doctors are killing black babies in like the first hours of life? I mean, what sort of vision of the universe do you have? I mean, isn't it logical to think more in the terms of what was ultimately discovered, which again does not seem like rocket science? I mean, maybe these babies were more unhealthy. Maybe they're more unhealthy. Maybe they're taking care of a different group of docs. So this should have been a really obvious thing to look at. And the most plausible explanation for why they did it is this was a result that accorded with their priors, basically.
Yeah.
Something that was interesting and important to find, which would fit into their worldview. And the more people do stuff like that, the more crappy research you get. But, as we were just discussing, once it gets out there, it's very hard to reel it back in, because that's what people hear of. That's the headline finding. It takes years for these things to be corrected and inevitably don't get as much publicity. Yeah. So, it's no wonder people believe a lot of dumb stuff.
That's right. We are teaching, unfortunately, I think we are inculcating that in the public, that doctors are racist. I think people think, we didn't think about that much. And as you said, most patients, Black and Hispanic, don't care. There was, in this talk I gave, I showed I tried to find, reliable, responsible polling. One was from Kaiser and the other was from U.S. News and World Report. And in both of them, almost the same data, that three quarters of minorities had no preference at all. Would you prefer to have a doctor of your own race? So 75% said no. And with the other 25%, I don't know what that means. Yeah, I prefer a Black doctor maybe, but it's fine if I don't get one. It's hard to know really the strength of that preference. It's I think we are actually spreading fear, in fact, making patients more paranoid with small p, hypervigilant to these kinds of things, to seek it out. I'm sure you've seen so many of these individual stories of patients who go to the ER and they're a minority and they think they're being discriminated against. And I want to scream at them. Everyone is treated, badly at an ER because.
All right, haven't you ever been at an ER?
A gunshot wound. You're not up first.
Right.
And but that's not, racism is not an explanation available to us.
Right.
So, and I could see again, based on the kinds of things that we're circulating in the media, why someone might choose that as their explanation. But we should know better as researchers, and it's stunning how many studies, which are correlational, not even causal, but invoke systemic racism, which it's not even scientific. I'm not saying this isn't a real phenomenon, but you have to operationalize everything when you do quantitative work. And systemic racism, even racism is not. I mean, the closest you can get is perception of racism. But, and even that you have to, you should measure carefully.
Yeah, that's logical question to ask. But if you're the first cut at these issues is not to ask the questions, because to ask the questions would in and of itself be evidence that you yourself are racist, sexist, transphobic, or whatever. Obviously, you're not going to get very far in drilling down in real causes and real variables and being able to quantify things appropriately, because it's just garbage in, garbage out. So it's all pretty pretty terrible. I just want to, speaking of things that are terrible, I just thought this was an incredible quote from Jennifer Nuzzo. This gets at the issue of trust in medicine and public health, which has accentuated the problem by the things you're talking about how people are trained and how racism, quote unquote, in the profession is lovingly dwelt upon. Jennifer Nuzzo, an epidemiologist at Johns Hopkins in June 2020, said the public health risks of not protesting to demand an end to systemic racism greatly exceed the harms of the virus. So we're talking about a virus that killed like billions of people. And this woman who's like allegedly an expert, on epidemiology and related issues is telling people racism is such a scourge that you must get out there and protest racism because it's actually worse than the harms of the virus. So, I mean, this is the kind of crazy town stuff that you get into once you become captured by this ideology. It makes people think, who are these people? Why should I trust the public health authorities? Why? I mean, they keep on saying dumb stuff and they keep on making mistakes.
Yeah, that particular incident was, I think, a real blow. To be fair, it's since taken down, as you can imagine, that tweet.
Of course.
This woman is a serious epidemiologist. She's I think Brown now, and she's very serious. But the spin that I will use is that she just got so swept up in this that she basically wrote an article, a tweet that you kind of get the sense of, but is incoherent. I mean, what are the metrics? How could you tell? But what most people fixate on when you show them that tweet, and has been in the media surrounding that tweet, because it did get a lot of publicity, is the hypocrisy of it. In other words, would you ever hear such a statement coming from a public health person if you wanted to go to a pro-life rally or, a religious? No, probably not. To be fair, probably not. But to me, what's more disturbing is the fact that a public health expert felt that it was kind of within the bounds of her role to advise people on which risks are worth taking. And their job is to tell, to the best of their ability, tell us what the risks are and let us as the public make our decision about what risk we want to take. And maybe we did want to take the risk of going to march for George Floyd. That's fine. But don't inject your own moral commitments into these things. That is a serious boundary violation.
And it wasn't just her, right? Wasn't there a whole association of progressive public health professionals and, 100,000?
Yeah, she wasn't alone. She got a lot of, got retweeted 1 trillion times. And then there was a letter signed by 1,200, open letter.
The 1,200 public health.
That basically echoed that. So, what was more, where we really, she's one person where we really dodged a bit of a bullet was when it came to the late fall of 2020, when the vaccine was on the horizon, but we didn't think there'd be enough of it at first, and there wasn't. So, it had to be rationed. And the Advisory Committee on Immunization Practices, which is within the CDC and advises the CDC on immunization practices, actually came up with the most tortured kind of algorithm for how the vaccine should be distributed, and it turned very prominently on race. Specifically, obviously in public health, you're looking at populations, you're not looking at individuals. So they looked at the population of people over 65 and 75, who every country, every doctor, every epidemiologist knew was the highest, probably the greatest single risk factor, all else being equal, for morbidity from COVID.
Right.
And it just so happened that if you looked at the demographic of the country, the percentage of white people over 65 was greater than the percentage of white people in the general population. So in other words, whites were disproportionately represented in that most vulnerable group. And that was their rationale for not giving the elderly as high a priority as they should have, as every other country did. That wasn't allowed to proceed, and there was an outcry. So, and CDC's own data projection showed that there would be more overall deaths if they followed through on this plan to prioritize race.
Yeah,
And
including
still
older Black people, right? Including older Black people, and higher percentages.
Oh yes,
die.
no, they would have been
It's crazy stuff.
most harmed. Yeah. So I mean, that was a real palpable one, and I've tried to come up with some other, because this is where I struggle. I think the whole culture of medical training is starting to it is a very unhealthy infringement. Now, when the door is closed and you're my patient and I'm a social justice doctor warrior, am I not going to say to you about, I'm not saying you have diabetes, I'm just making this up, about your diabetes,
right.
Maybe don't worry so much about your diet or taking your medication or exercise, because we all know that it's external forces that are impinging on you. And I don't believe that. So I'm always struggling with, how is this going to ultimately play out? I do think one of the most worrisome elements of all this is the affirmative action, because we are lowering standards for excellence. We've stopped grading a certain test, the United States medical licensing exam. Now it's pass-fail, and there were two main reasons given for it becoming pass-fail. One is lifestyle issues, because we're making poor medical students work too hard. But the other was the fact that minority students didn't perform as well. And so this is something I worry about.
Yeah, no, I think that is the essence of it. I mean, again, common sense would suggest that when other criteria besides merit are factored into who becomes a doc and who does not, you will get less good doctors. You just will. If other factors and scientific rigor are walked into research, you will get less scientific and less good and less fruitful research. So we haven't yet, hit some spiral where the bottom is falling out of medicine in the United States. But, there's no way this is a good trajectory. We see a lot of things happening that are not good. And, inevitably this has and will continue to have, and it'll probably get worse in terms of how it impinges upon the ability of doctors to give people the treatments they need. So, and continue to undermine trust in U.S. medicine and the medical establishment. And I might add, maybe we'll conclude on this, Sally, because you had a piece along some of these same lines in a great book that recently came out, The War on Science, edited by Lawrence Krauss, which basically takes a look at a lot of these trends and how they have affected way beyond medicine in STEM science, in the sort of all overall scientific fields. And it's pretty worrisome. I mean, heck, if they can hit math and physics, it can hit everywhere, right? I mean, this is a broadly gauged trend. I mean, the days are gone when all you had to worry about was the English department and the gender studies department, right? I mean, we've blown way past that. So, and again, the effect of these kinds of trends in any kind of scientific endeavor has got to be bad, right? Once you take merit and rigor out of the equation and you dump a lot of other stuff in, bad things will obtain. So, there we are in both medicine and overall. And so, I mean, is there any reason to think that war in science is failing, at least to some extent? I mean, we now do have, obviously Trump has pushed back in some of this stuff, but of course he's completely overdone it, as is completely predictable. So, I'm sort of wondering, what the future might hold in terms of this. Because, we're not in good shape in terms of educational outcomes of the people in the pipeline who are going to eventually go into various fields, including STEM. Our ability to compete with our competitors in the People's Republic of China would appear to be somewhat in doubt, in addition to the generic problem of how well do we treat our patients.
Yeah, well, there are, efforts to at least shut down DEI bureaucracies, which that's important. I'm sure the new head of NIH is not going to uphold, is probably already reversed the idea of pledging. It's for grants. Sometimes you have to make certain pledges. You have to pledges to the social justice agenda. You have to demonstrate, air quotes, that your study will somehow somehow advance social justice. And I think all that kind of silliness is going away. But just the other day, there was an article in Nature. That's a British publication, but it's like the equivalent of Our Science.
Right,
here.
right. Yeah, I know it.
And they actually have a position now that if you submit a paper to us, we're going to comb through the citations to make sure that the authors in those citations of those studies that you've cited are diverse enough. This is just, yeah, it's absolutely unbelievable.
Madness, Sally, madness. How does this happen?
Madness. It is madness. But in medicine, we could, I'll just read you this because it's so frustrating. So much of this has to do with where these young folks, these new doctors, want to situate themselves. So they're big on a lot of the social justice rhetoric, but do they work in the areas that are the most underserved? The answer is no.
No.
Yeah. So here's this study I want to just mention quickly. Last spring in JAMA, Journal of the American Medical Association, found that newly licensed clinicians, doctors, from top-ranked medical institutions were half as likely to initially practice in socioeconomically deprived areas as those from other medical institutions, and that specialists were less likely to go to those places. If you're, if you're that worried, and believe me, after my year in Ohio, there's good reason to worry. That's where you should work for a while. It's very rewarding. And a study in 2020, this out of Stanford, I'll just quote this quickly, young physicians in the prior decade, so that's 2010 to 2020, had been moving and then their phrase is sharply to the left, and pardon me, and flocking so densely to urban areas, he and his colleagues called it ideological sorting, that rural areas were suffering from shortages of physicians. This is the same point, but it's clearly a replicable finding.
Yeah. So I want to practice. Yeah, I want to practice social justice so long as I'm surrounded by other people in an appropriately affluent area who all agree with me. So it's ironic in the highest. So
and the thing is, it all falls away when you're a clinician. It's you and the patient. The disparity issue to a clinician is meaningless. The only disparity I care about is the gap between your current health, if you were my patient, your current health and your your optimal, reasonable health. That's what I care about. And then when you leave the office, I say that to the next Black patient who comes in. I mean, this is not something that clinicians, it's not even it shouldn't even be really in their realm of practice. It's fine for them to have these facts that there are these differentials. And again, maybe they do certain research that might make them useful to politicians who were, making policies. But at the level of the physician, this is irrelevant.
Yeah. Amen, Sally. That's what you care about. And I think that's all normal people care about. They care about that gap between their current health and the health they aspire to. That's what they want your assistance with. The rest of the
disparity.
Stuff
That's
it's like second, third, fourth order effects, like it's just get out of here. Just treat me, cure me. I want a doctor who can help me do that. So with that blast of common sense, I think we'll sign off here. I want to urge everybody to follow Sally's writings. Look at her previous books that have come out. Keep an eye out for the book that even now she is beavering away on. And, I think if you take cognizance of Sally's work and others like her, you'll be enlightened about the state of medicine in America today and the ways in which it really does need improvement. So we all can be as healthy as we can possibly be. The real Make America Healthy Again. That's what we're talking about. It's the real Maha here. So anyway, thank you, Sally, for being in the Liberal Patriot podcast. And let's have lunch sometime in our lovely cafeteria.
Sounds good to me.